I want to talk today about groundbreaking trials that were presented at ESC 2025 that are potentially practice changing. That will also give me an opportunity to discuss some general cardiology ideas. First, I want to describe the saga of beta blocker use post-MI. There were two major trials presented, the reboot and the beta-me then block. Those trials assessed beta blocker use post-MI, whether STEMI or non-STEMI. Half the patient almost were STEMI, who also had an EF over 40% and in whom beta blockers were initiated early on within 7 days, typically during the hospital stay, and they were followed for about 3.5 years. Reboot was completely negative on mortality and recurrent MI, whereas beta-me then block was mildly positive in terms of reduction of recurrent MI. So here is my take on all those trials, including two other trials that were published in the last year. So in the reperfusion era, in STEMI or non-STEMI with an EF over 40% and without heart failure, some randomized trial showed a marginal benefit of long-term beta blocker therapy, while others did not. For example, reduce AMI, which randomized patient with an EF over 50% with either STEMI or non-STEMI, 35% were STEMI. And the other trial, a reboot trial with EF over 40%, in those two trials, beta blockers initiated in the hospital did not reduce death, MI, or heart failure at 3.5 years of follow-up. They were completely negative. On the other hand, you have beta-me then block, which showed that beta blocker initiated within 7 days of MI mildly reduced reinfarction at 3.5 years of follow-up by only 1.7% at 3.5 years. So less than 0.5% per year, and without a mortality effect. And there is another trial, the ABIS trial, published in the last year, which took patients with an EF over 40% after an MI. And this trial randomized patients to beta blocker interruption more than 6 months post-MI versus continuation. And this trial showed that beta blocker interruption at more than 6 months was slightly harmful. It was associated with a slightly increased angina risk, no difference in mortality or MI. Now, a meta-analysis that included those two trials analyzed patients with an EF of 40 to 50%. And that meta-analysis that included beta-me and reboot showed a more marked benefit in the EF of 40 to 50% subgroup, where death and heart failure tended to improve. They were not significantly improved, but they tended to improve, beside a tend to improve reinfarction. However, even in that higher risk group, the benefit remained only mild. The MI was 1.18% versus 1.51% per year. So you had a reduction of MI of 0.33% per year. You had death 1.71% versus 2.19%. So 0.48% reduction of death per year. That was not statistically significant. Again, some reduction in heart failure, not statistically significant. And the combined endpoint was reduced by about 1% per year. Now, those numbers are small in absolute value. And keep in mind, whenever we analyze cardiology trials, don't make the mistake of looking at relative risk reduction. In this group of 40 to 50%, beta blocker led to a relative risk reduction in combined endpoint of 25%, but in absolute value, it was only 1% per year. So it is beneficial more in that subgroup than in patients with EF over 50%, where the benefit, if present, was even more marginal. However, it is still a mild benefit. And here I said that the trend toward mortality reduction was 0.48% per year. But keep in mind that a completely unrelated trial, the SPRINT trial in hypertension, which drove the hypertension guidelines and made those guidelines push for aggressive blood pressure control to less than 130 compared to less than 140, The sprint trial, actually, there was a mortality reduction of only 0.37% per year. Make what you want out of it, but just know that number. That's what drove those guidelines in hypertension, 0.37% per year. It's important to know data beside guidelines. And that was 0.37% reduction in high-risk patients, many of whom were older patients. Benefit may accumulate over time, 0.37% per year. I would think that the benefit is greater in younger patients who have a larger time horizon, 20, 30 years, to benefit from a reduced blood pressure. Yet, interestingly, because younger patients are lower risk patients who may not even have that 0.37% per year mortality reduction, the hypertension guidelines are less aggressive in blood pressure therapy in younger patients whose risk score is less than 5 to 10% at 10 years. So it's interesting how those guidelines get formulated based on small numbers. Anyway, to go back to beta blockers post-MI, in sum, here is how I see it. The long-term use of beta blockers seems reasonable and mildly beneficial in post-MI patients with EF of 40 to 50%, and even in those with EF more than 50% based on the BETAMI then block trial, but individualize and take into account the patient's risk profile, the more extensive his CAD, the less revascularized his CAD, the more extensive his COD history and MI history, and take into account the presence of angina or hypertension, and keep in mind that the benefit, if present, is only mild reduction in MI and possibly a reduction in the combined endpoint, more so in the F40 50%, but also the absolute risk reduction is relatively mild. So it's reasonable to use them in those subgroups, but I don't think it should be mandatory. And keep in mind another important idea that low to medium doses are better tolerated and likely equally beneficial in this post-MI setting. This is based on a Danish registry published several years ago, but it's also based on the BETAMI trial, the one that showed a marginal benefit of beta blockers post-MI. In that BETAMI trial, the beta blocker dose used was actually metoprolol 50 milligram or less in more than 90% of patients. Also, aside from this idea of long-term therapy, I still consider acute therapy with beta blocker for 1 month, starting at 24 hours or more, to improve early LV remodeling and ventricular arrhythmia as per COMET CCS trial. When initiated in the first day, there was an increased risk of cardiogenic shock, and the overall effect of beta blockers were neutral when initiated the first day. However, beyond 24 hours, beta blockers started to become beneficial, and this study used beta blockers for 2 to 4 weeks post-MI. Now, based on the COMET CCS trial, beta blockers may be started on the first day if you do not have any high-risk features predictive of cardiogenic shock, such as any degree of heart failure or a borderline blood pressure or a heart rate that is over 110. So in the absence of those features, you may start beta blockers the first day. There is no harm of starting them the first day, but even in that scenario, without high-risk features, there is no benefit of starting the first day. Yet I would consider starting them the first day in that case. Otherwise, definitely the second day. Also keep in mind that beta blockers are definitely beneficial in EF less than 40% post-MI, as in the Capricorn trial, where carvedilol was started at 3 days post-MI. And here is a very important idea. Patients with heart failure and EF less than 40% are those who benefit the most from beta blocker post-MI, and those are the ones who absolutely need beta blocker post-MI. But those are also the patients who are most hurt by very early initiation of beta blocker. Okay? And in general, even without heart failure, I favor initiating beta blockers at 24 hours or more for 1 month. Then beyond 1 month, you may continue beta blocker based on what I described here, but it is not mandatory. And it's very interesting that the 2025 ACS ACC guideline, they give a class 1 for beta blocker post MI, regardless of EF, with really no modern data for that. And paradoxically, they recommend the initiation of beta blocker at less than 24 hours, even though Comet CCS trial demonstrated that the benefit from beta blockers start at beyond 24 hours. Now I'll move on to another major idea. It's the saga of non-culprit PCI. So we know that in MI, whether STEMI and non-STEMI, besides fixing the culprit artery, it's beneficial to fix the non-culprit artery and lesion rather than leaving those alone and treating them medically. This is based on the complete trial, which took STEMI patients and performed non-culprit PCI before discharge or within 6 weeks, and non-culprit PCI was associated with a significant MI reduction. This is also based on the FIRE trial, which took STEMI and non-STEMI elderly patients and performed non-culprit PCI, whether immediately in the same setting as the culprit or before discharge. And this FIRE trial showed a mortality reduction with non-culprit PCI. And this is also based on a third important trial, the SLIM trial, which was presented and published during that same ESC 2025 meeting. And this SLIM trial was a dedicated non-STEMI trial, the only dedicated non-STEMI major trial, and showed that non-culprit immediate PCI reduces adverse cardiac outcomes, mainly reduces the need for future revascularization without a significant reduction in MI or death compared to leaving the non-culprit alone. However, none of those trials specifically addressed when to do non-culprit PCI. What's the best time? And is it different between STEMI and non-STEMI? We know that in non-STEMI, it's difficult to identify the culprit lesion. In fact, based on MRI studies, the culprit lesion is misidentified in about 35% of non-STEMI patients. This is beside the fact that in 40% of MI patients, we have multiple complex plaques, over 50% stenotic, and it may be difficult to differentiate which one is the culprit. So anyway, what is the timing of non-culprit PCI? Should it be during the culprit index procedure or in a second procedure only a few days later before hospital discharge, or as an outpatient few weeks later, as it was an option in the complete trial? My preference has always been for number 2, in a second procedure before hospital discharge. So 2 trials previously attempted to answer that question. The BioVasc trial randomized patients with STEMI or non-STEMI to immediate non-culprit PCI versus a staged non-culprit PCI several weeks later. The mean was around 15 days. And in BioVasc trial, immediate non-culprit PCI was as safe as delayed PCI a couple of weeks later. And in fact, it trended to be better to do immediate non-culprit PCI. That was associated with numerically less recurrent MI and significantly less recurrent MI in non-STEMI, or in the case of a total contrast load less than 220 milliliters. So the conclusion of BioVasc was that immediate non-culprit PCI in the same setting as primary PCI may be considered if the lesion is simple and quick, renal function is preserved, the contrast load is less than 220, and the patient is not too sick to tolerate it, particularly in the case of non-STEMI. And here is the kind of dichotomy in non-STEMI versus STEMI. Otherwise, in the absence of those features, if the lesion is complex, do non-culprit PCI later, but preferably within days. Unlike BioVasc, where that non-culprit PCI waited weeks, maybe we should wait days, which is something that BioVasc did not address. Immediate versus days, this was not addressed in BioVasc. Now we have another trial, purely STEMI, multi-stars. This randomized STEMI patient with multivessel disease to immediate non-culprit PCI versus late stage non-culprit PCI 19 to 45 days later. The mean was 37 days later. And evidently in that trial, there were less MI in the immediate PCI partly because the waiting time was too long. This was not a stage PCI a few days later. Another trial methodology idea that favors immediate non-culprit PCI in those trials is that in immediate non-culprit PCI, you inherently tend to get less peri-procedural infarcts counted, simply because it's hard to gauge how much myocardial injury you're getting from that non-culprit PCI when your troponin is already rising and dramatically rising in the acute setting and the patient is already having chest pain. Now here comes the OPTION-STEMI trial from the ESC 2025, which I think is one of the most important trials presented. The OPTION-STEMI took patients with STEMI and multivessel disease and randomized them to immediate non-culprit PCI in the same setting as culprit versus non-culprit PCI to be performed a few days later, typically before hospital discharge at a median 3 days, 2 to 4 days range. The immediate performance of non-culprit PCI was associated with more cardiogenic shock and numerically more death than stage PCI performed a few days later. The increase in death was not significant at 30 days, and at 1 year, it was significant at 6 months. Now, this increase in cardiogenic shock and numeric increase in death was driven by the fact that this trial, unlike the prior ones, included a significant proportion of patients who had heart failure, KILIP class 2 or 3, meaning mild heart failure or severe massive pulmonary edema. 33% of patients had KILIP class 2 or 3. And those are the patients who are significantly harmed by immediate PCI, as those patients do not tolerate any unnecessary additional procedural or ischemic time. And you can see here the mortality, which was numerically higher, and it was significantly higher in the immediate group at 6 months. And you can see the cardiogenic shock was double in the immediate group, particularly in patients with KILIP class 2 or 3. And many conclusions can be drawn from this trial. And the first one relates to the timing of non-culprit PCI. Based on the combination of data from OPTION-STEMI and BioVasc trials, it seems best to me, at least in the case of STEMI, to perform non-culprit PCI in a stage separate procedure few days later before hospital discharge. What made delayed PCI beneficial in OPTION-STEMI is the fact that in OPTION-STEMI, unlike BioVasc, the delay to that stage PCI was short, few days, not weeks, and this prevented the risk of non-culprit artery-related MI in the waiting time. A second message potentially from OPTION-STEMI is that stable patients without any degree of heart failure, KILIP class 1, may undergo non-culprit PCI in the same setting as culprit PCI, especially in the case of non-STEMI, if the lesion is simple and quick, renal function is preserved, the contrast load is less than 220 milliliter, and the patient is not too sick to tolerate it, whether from a heart failure standpoint or from an age and agitation. And within this idea, there may be this dichotomy between non-STEMI and STEMI. ESC guidelines for ACS favor multivessel PCI in the same setting in non-STEMI, whereas the ACC guidelines allow the non-culprit to be performed in the same setting or a few days later. They don't give a preference. I think based on the data in non-STEMI, you can do multivessel PCI in the same setting or a few days later. But again, far more importantly, take into account how sick the patient is to tolerate the procedure, make sure he doesn't have any heart failure, what's his renal function, how much contrast you use, how complex the lesions you are treating are, and how tired you are while doing those procedures. But try not to postpone the second PCI too late unless the patient develops acute kidney injury. And the third and most important message to me from this trial is that it's reminiscent of the culprit shock trial, wherein patients with MI and cardiogenic shock in the culprit shock trial, or in this OPTION-STEMI trial, severe heart failure, KILIP class 3, or mild heart failure, KILIP class 2. In those patients, be as quick as you can, treat the culprit and get out quickly. Limit your procedural and ischemic time. That's a message from those trials. And I would extrapolate those messages not just for STEMI. For non-STEMI, you have non-STEMI with heart failure or cardiogenic shock. Do not rush this patient to the cath lab. In fact, as I showed in my prior talk of cardiogenic shock tips and update, the only trial that showed a benefit of revascularization in cardiogenic shock was the shock trial, which took acute STEMI cardiogenic shock. So the only time where revascularization benefits cardiogenic shock is acute STEMI shock, and just do the culprit. There is no data for immediate emergent PCI or revascularization in non-STEMI cardiogenic shock compared to waiting until stabilization. And I would argue, as an extrapolation from the culprit shock and now the OPTION-STEMI trial, you should avoid treating what is not strictly necessary in a tenuous patient with shock or bad heart failure or any heart failure, and rather wait until stabilization with diuretics, pressors, anticoagulants, and even support devices as needed in cardiogenic shock. Somebody with non-STEMI without ongoing ST elevation or without ongoing and profound ST depression, there is no evidence that rushing him to the lab will help him. And I'm deriving this extrapolation because, as it is in STEMI non-culprit PCI, whenever you have a lesion that is not causing an ongoing ST elevation or maybe ongoing and profound ST depression, there is no evidence that fixing this lesion emergently in the acute setting is beneficial. In fact, now we have those two trials showing that you may hurt the patient by rushing and doing PCI without ongoing ST elevation from that lesion. And I may say, if you have ongoing and profound ST depression, then I would perform emergent acute revascularization in a non-STEMI setting. But outside that, I would not rush the patient with cardiogenic shock or severe heart failure and non-STEMI to the cath lab. I would wait till stabilization. That also applies to what we call cardiomyopathy cardiogenic shock with underlying severe CAD and type 2 MI. Cath later after stabilization. Now, if the patient does not stabilize, place urgently a support device likely in the range of Impella CP and do urgent PCI afterward in a protected fashion. And typically, you need to intubate those emergent heart failure PCI before cath. And here are the reasons why any unnecessary PCI in the acute setting will make the patient worse. Because any prolongation of the supine positioning or the contrast loading or the ischemic time during PCI, every time you advance a balloon stent, especially in difficult cases, you're creating ischemia. Every guide ventricularization, deep guide seating, side branch losses, no reflow, all those will cause ischemic time and injury that is less likely to be tolerated if LVDP is high and blood pressure is low or borderline if the patient is tenuous. You may precipitate a downhill course of shock and massive pulmonary edema if you don't absolutely need it. And why am I insisting on that? Because I've always been dazzled by the non-STEMI guidelines, which without any data and without any common sense, recommend in non-STEMI to perform emergent PCI in case of cardiogenic shock or acute heart failure. This is in the ESC guidelines, but also in the recently published ACC guidelines. Look what they say. If you have cardiogenic shock or signs of symptoms of heart failure with non-STEMI, they want you to do immediate invasive strategy. There is no data for that. In fact, extrapolation of the current data, including the OPTION-STEMI, even though it's a STEMI, but it's an extrapolation of a common sense idea, it argues against that. I mean, they give it to class 1 with really no data.